Welcome everyone. Today I'm going to present to you my PhD thesis, which is using personalized treatment to improve early resuscitation in septic patients. Sepsis is a life-threatening condition responsible for 11 million deaths worldwide. Fluid resuscitation is the cornerstone of treatment. Guidelines recommend a fixed volume of fluid resuscitation. However, personalized therapy may lead to better outcomes. In our systematic review and meta-analysis, we found that personalized therapy reduces the 30-day mortality by 35% without increasing the odds of any adverse events. Clinicians should apply personalized treatment during their clinical practice in patients with septic shock. Therefore, further trials are needed to investigate the best strategy for personalization. According to our findings, guidelines on fluid therapy should be revised. My name is Gábor Nagy. I work at the Department of Emergency Medicine at Semmelweis University. I'm a PhD student as well, and I envision a healthcare system where each patient receives the care that is best for them, and my mission is to eliminate non-evidence-based data to improve survival in sepsis and septic shock. To make it happen, I have two ongoing projects. Both of them started last fall. Let me talk about my first one, which is comparing the safety and effectiveness of personalized versus fixed volume resuscitation in septic patients. As I mentioned, sepsis causes the death of more than 10 million people every year. Fluid replacement is an immediate priority and plays a fundamental role in the treatment of sepsis. Current guideline recommends a fixed volume of fluid resuscitation, which takes into consideration only a single factor, which is the patient's weight. But as clinicians, we are treating individuals, and we are well aware of the fact that one size doesn't fit all in medicine. Fluid resuscitation can act like a double-edged sword. It can save lives by restoring hypoperfusion, increasing cardiac output, and the oxygen delivery to tissues. However, numerous studies have reported the harmful effect of inappropriate fluid administration, such as fluid accumulation syndrome, which can seriously impair the function of vital organs, especially the kidneys and the heart. Resuscitation based on personal physiological needs is widely accepted, but the evidence on its efficacy and safety is still limited. Therefore, our aim is to investigate the effectiveness and safety of personalized fluid resuscitation compared to fixed volume or other non-personalized approaches. Our clinical question is personalized fluid resuscitation safer and more effective compared to fixed volume fluid strategy? To answer our question, we use the PICO framework. We investigating septic patients. Two types of treatment would be compared to each other. The personalized strategy based on the assessment of fluid responsiveness and the guideline recommended fixed volume strategy. Our main outcome will be 30-day mortality, and the secondary ones are organ support 3 days, length of ICU stays, and SOFA score changes. We hypothesize that personalized therapy is associated with better outcomes compared to guideline recommended fixed volume strategy in sepsis. We conducted a systematic search with two domain search key. Domain 1 refers to the population, and domain 2 covers the interventions. At the very beginning, we had started over 9,000 hits, and at the end of the procedure, we have 10 eligible articles for our meta-analysis. We are having 8 outcomes. I'm going to present to you one of them. Our main outcome will be 30-day mortality, which is the most important and hard outcome in critical care, because we want our patients to survive. This outcome, regarding this outcome, the effect size is odds ratio. It was reported in 9 RCTs. Approximately 1,000 patients' data were assessed, and with a moderate heterogeneity. And as you see, the overall effect is the odds ratio of 0.65, which means that personalized fluid therapy will reduce the 30-day mortality by 35%. This suggests that personalized fluid therapy should be prioritized over fixed volume fluid therapy. Regarding to our secondary outcomes, we investigated the need for organ support. Organ support is a very important indicator of the severity of illness and the patient's overall condition. Two of them were assessed: duration of vasopressor therapy and requirement for renal replacement therapy. Regarding these two secondary outcomes, we didn't find any significant difference between the two strategies or between the two groups. As we finish the grade assessment, we are planning to start to write the manuscript. Our study has some strengths and limitations as well. The strengths are only RCTs were included, and this is the first meta-analysis indicating that personalized treatment has potential outcome benefits in septic patients. And it also limited by the moderate to high heterogeneity, and different techniques were used to assess the fluid responsiveness in the intervention groups. The main conclusion is that personalized fluid management may improve survival as compared to conventional treatment, and the implication for practice will be personalized approaches should be facilitated to become standard of care, and the implication for research is the best way for personalized strategy has to be further studied. So as I mentioned, we plan to start the manuscript writing, and we hopefully ended it in the beginning of July. Let me have a brief introduction about my second project, which is investigating the effectiveness and safety of immediate vasopressor initiation in patients admitted to the emergency department with shock. This is a protocol for a randomized controlled trial. Shock leads to hypoperfusion and organ dysfunction with a high mortality rate. Hypertension, when mean arterial pressure is below 65, is an alarming signal of hypoperfusion, which can increase the risk of major adverse cardiac events and acute kidney injury as well. But it can increase mortality, as you see depicted in the figure. The longer time you spend in shock with the lower MAB, you have the highest chance to die. Sorry for this background. So current guidelines recommend fluid first and vasopressor as second-line treatment, but there are no clear evidence or guidance on the time, which is a crucial part of critical care, of vasopressor initiation. Our aim is to investigate the efficacy and safety of immediate vasopressor combined fluid therapy in patients admitted to the emergency department with shock. Our aim is supported by a recent published meta-analysis as well. Our clinical question is that regarding this topic, does immediate fluid and vasopressor initiation enhance shock reversal without causing harm in ED patients with shock? We are using the PICO framework to answer these questions. We are investigating patients admitted to the ER with undifferentiated shock. It's defined when mean arterial pressure is below 65 and the lactate level is above 2 millimole per liters. In the intervention arm, the patients will receive immediate fluid and vasopressor initiation, and the control group's participants will receive fluids first, and if they are proven to be fluid unresponsive, they will we are going to initiate vasopressors as well. Our main outcome is the rate of persistent shock after 3 hours of resuscitation, and our secondary outcomes are 30-day mortality, ICU admission and length of stay, and SOFA score changes. Our hypothesis is immediate initiation of vasopressor leads to better outcomes in ED patients with shock. The clinical implication will be enhanced recovery from shock. To summarize, I have 2 ongoing projects. The first one will be submitted as it planned this September, and the second one will be finished in next November. I would like to close my presentation with a quote: "Believe you can, and you are halfway there." Thank you for listening.
In your second project, you mentioned the immediate fluid and the vasopressor. So I don't know if you have any articles yet for this, but if you do the articles all use the same kind of vasopressor? Because aren't there different kinds of vasopressors that take different lengths of time to start working?
No, thank you for your question. The vasopressor will be initially used is norepinephrine. Going to be I think in most of the cases, yes, but it's a very early phase of this study and we have to draft it.
I would have the question that in your first project, what does it exactly mean? How do you measure this personalized volume therapy? How much volume do you give to each person? What are the criteria, or how do you measure that?
Thank you for your question. It's a bit difficult to answer, but the evaluation of fluid responsiveness needs an additional tool, which is mostly an ultrasound guide or passive leg raising. And across the studies, the method of assessment was very different. So I think the best way and the easiest way to assess the fluid responsiveness after a fluid challenge when you administrated a defined bolus of fluid and after the patient received it, you will evaluate his fluid responsiveness. It can be guided by ultrasound, measure the IVC diameter, the inferior vena cava, or the patient's individual heart function. It depends on many factors, but it's very useful and very beneficial for the patients if we guide this therapy according to these aspects.
Nice, thank you.
Thank you.
You mentioned that this personalized approach is better than the fluid ratios interventions. And my question is whether there is a difference in time spent in shock between the two groups.
You mean in the personalized and the fixed volume?
Because using the personalized approach, it's a bit more complicated as compared to just give 30 ml of fluids to these patients. And maybe it's needed more time to make my decision, so that's why.
Yes, but unfortunately, none of the articles reported this outcome, unless in spite of the fact that it would be very, very, very important.